So my name is Dr. Gaurav Thukral. I am the Chief Operating Officer for Healthcare at Home India, and I'm based out of Noida. So ICU in a hospital is a place where patients needs continuous monitoring, where interventions are required to be done any point of time in 24/7 care. But when you step down the same ICU care, which for want of one-to-one nursing becomes difficult in the hospital, we take that transition of care with the same quality at home, making it ICU at home. So for example, as a doctor, if I know that this patient is recovering, and if I keep this patient in the hospital for some more days, he will catch an infection from a fellow patient, or he will block a bed for somebody who needs his care more and is waiting in the emergency. Now I can't send this patient to my HDU or to my ward, because I am not sure whether that he will get that one-to-one nursing or not, right? Or will he get that step down care which I feel I am more confident of giving in my ICU. Those patients, we take them home with the same quality care, with our trained people, with all infrastructure, and still keep that hospital doctor connected with the progress of that patient. The whole technology-enabled systems are equipping the doctor to treat these patients even when the patient is not in the hospital. And that's whole concept which we call is the future of ICU, is ICU at home. Yeah, the biggest challenge is making people understand that this can be done at home. So the whole challenge of home care is a staffing solution versus a managed care. What home care is benchmarked to is nurse at home. And I fail to understand that when in the hospital the care is being delivered by a nurse, a physiotherapist, a dietitian, even a GDA, with n number of people working in the back end, under the supervision of the doctor, they carry out the care plan. How do we expect that the same patient, when he walk out of the hospital door, can be managed only by a nurse? So the perception of managed care at home, delivering a post-operative care, delivering a critical care, delivering a onco care at home is where we struggle. People still benchmark it to a nurse. Getting the right people to deliver that care, people who are confident, who are communicative enough, because in a hospital, the visitors or the family gets to meet the patient only for maybe 5 to 10 minutes in a day. In the home, you can't tell them you can't meet your people, and you are under a scanner. The person who's treating the patient at home has to be confident. He has to explain things, why I'm doing this, and whatever I'm doing, I'm in control. So getting that right mindset of people, our education system doesn't give us that education that we can communicate and explain things. So even if you get best of the nurses who have best of the expertise, communication soft skill again is a big problem. Given the fact that nurses have to be upped. For example, we have this concept of physician assistant, where we said we are not getting enough surgeons, so let upgrade nurses to being physician assistants or nurse practitioners. In our case also, we have to uplift the nurse to do very specialized jobs and create another cadres of nursing assistants, healthcare assistants, who can do care of bedridden, who can do all that work and free the nurse to do more quality work. So getting people and building this cadre will again take time. So today, if you are treating patients across 100 beds across the country, bridging this distance itself is a huge challenge. And we have tried to solve this challenge just by leveraging clinical quality, by leveraging technology. So in a hospital, the document which is sacrosanct and which dictates the treatment of the patient is the file in which everything is being documented. That is the file which can be also challenged in the court of law to say whatever was done was medically, ethically and quality benchmarked or not. Similarly, what we have done is we have replicated that file onto tablet devices which our nurses use. All the data comes real time into those tablet devices. This data is collated and sent to the treating doctor and the family to tell how the care plan is being delivered and what is the progress of the patient. Also, we have a set of intensivists who remotely monitor our patients through a command center, and these would be as good as doing morning, evening rounds or transmitting 24 hours data from these beds. So technology has enabled our doctors and our staff to be connected for the benefit of the hospital. Also, all the equipments, whether it's oxygen, whether it's a syringe pump, whether it's a monitor, whether it's a ventilator, all the data from these devices can also be seamlessly transferred back to the doctor, and any alerts can be taken care of. Well, this is the future. I think we have just at that inflection point where people have started realizing that such patients can be treated at home. And today ICUs are choked. 30% of the patients in the ICUs are there just because there is no one to take them out of that place. And there are 40% patients who do not get ICU because ICUs are only in those tertiary care centers which are located in those few metros, right? With ICU at home concept coming back, we'll see a pattern where patients who are coming to these metros will not get stuck into those hospitals but can go back to tier 2, even tier 3 cities where we can set up the ICU at home, and this will increase a lot of accessibility. Second I see is affordability, where ICU at home is less than 50% of the cost that in the hospital. So I see that ICU at home should boom and it should provide access and affordability to care.